I've been having some challenge. But can you see my slide now?
Yeah, and it's on slideshow. Clear, very clear.
Thank you.
Okay, so you have the floor. Go ahead.
Is it moving?
Yeah, it's moving. It's moving.
Okay,
Fine.
thank you. Good evening, consultants, senior colleagues, and colleagues. Today, I'll be talking on the pharmacology of anticoagulants, and I'll be using this outline, brief introduction, would classify, give mechanism of their action, and then talk on some clinical entities, and then conclude. Thrombosis, like we know, is a blood clot, and it is usually a clot that is found within blood vessels, which can limit the flow of blood. And when this occurs, it carries varying impact depending on the degree of occlusion. And thrombosis can occur in the arteries or veins. And when they do occur on the venous side, they cause deep vein thrombosis and pulmonary embolism, both of which are known as venous thromboembolism. And when they occur on the arterial side, they are most commonly the cause of myocardial infarction, ischemic stroke, and acute limb ischemia. And both the arterial and the venous thrombosis are said to be responsible for over 10 million deaths. Now, in terms of the component of thrombosis, all thrombosis have similar components, but the composition may vary in terms of the content. So all thrombi are essentially consisting of aggregated platelets. We also have fibrin and then trapped blood cells. But depending on whether it is venous or arterial, the components will vary, or the proportion. So arterial thrombi are mostly rich in platelets, and because of this, they appear white, and they can be called white thrombi. And this is because they have a high shear stress in terms of the vessel where they are found, which are arteries. And then most arterial thrombi occur as a result of a disrupted atherosclerotic path, which exposes thrombogenic materials in the plaque called to the blood. While the venous thrombi, they usually form under low shear condition or pressure. And because of this, they contain relatively few platelets, and then they are mostly composed of trapped red cells and fibrin. And this is what makes them appear red. So if you, they are also known as the red thrombi, which is the venous thrombi. And usually they originate around the valve cups of deep vein, where you have sluggish blood flow. And because of this sluggish blood flow, you have endothelial cell lining around the cups, which can get easily activated and express adhesion molecules on the surface. And then they are also associated with tissue factor, bearing leukocytes and macrovesicles, which adhere to these activated cells and induce coagulation. Like we remember in the vitreous triad, which is of historical significance, a major predisposition for thrombosis includes three things, which is endothelial damage, you have hypercoagulability, and then venous or arterial stasis. And then recent advances now in understanding of the contribution of thrombin generation to arterial thrombosis and the role of platelets in venous thrombosis has prompted new treatment paradigm. The next diagram here actually is just helping us to see what we have in the setting of an arterial thrombi or venous thrombus. Now, the first picture by the left shows us what happens usually when you have a vascular injury. You would have some form of an attempt to arrest that breach in the endothelium. So when that happens, you have first the vascular spasm, then aggregation of platelet plug, and then fibrin mesh to seal off that area of impact. But if you look at the arterial thrombus, you would find out that most of the cells are actually within the intravascular space. You find that they are mostly platelets, so they appear white. That's the white thrombus. And then if you look just above the small muscle cell, that's above this point here, you see that these are actually foam cells. And that is why the arterial thrombosis is usually the result of a rupture of a plaque. Then if you look at the venous thrombus, you have less platelets. These are platelets, they are less, but you have more and more of trapped cells, mostly red cells, and then the presence of these strands that are fibrin. So that can help us to effectively differentiate them. Then in terms of thrombus, of hemostasis, hemostasis is prevention of blood loss, and it is actually divided into 4 stages, like I mentioned earlier. First, when you have an injury, there will be a vascular spasm, and then you have the formation of the platelet clog, and then it stimulates the coagulation process, and then the termination of that clotting process by the normal mechanism of anti-thrombosis. And then you now have the last aspect, which is actually the fibrinolysis, where you have resolution of fibers. As a reminder, we would recollect that there are various clotting factors, and this is important to recall because of the cascade of coagulation. And factor 1 is fibrinogen, 2 prothrombin, factor 3 thromboplastin, factor 4 is calcium, 5 labile factor, 6 it's not yet known, okay, but some people call it accelerating. Then 7 is stable factor. Then you have factor 8, which is the anti-hemolytic factor. Christmas factor is 9, short power factor is 10. Factor 11 is plasma thromboplastin antecedent. 12 is the Hangeman factor. And you have the fibrin stabilizing factor, which is factor 13. So generally, when we talk about antithrombotic medication or treatment, it actually has to do with 3 major things. If you talk about antithrombotic therapy, you're talking about antiplatelets, you're talking about anticoagulants, and then you're talking about fibrinolytic agents. These 3 make up antithrombotic mechanism or medications or drugs. But our focus today is on the anticoagulant drugs or medication, looking at their pharmacology and pathway. So anticoagulants are the mainstay of prevention and treatment of venous thromboembolism, and they can be parenteral or oral in terms of their formulation. So recapping now the pathways for coagulation, we recall that there are 3 major pathways. We have the intrinsic pathway, the extrinsic pathway, and then we have the common pathway where the intrinsic and extrinsic actually can meet at that point. So the extrinsic factor or pathway is usually when there's contact with tissue factor, and the process starts with factor 7 being activated to 7 activated, and then 7 activated in the presence of factor 9 and 9 activated, and calcium will now activate factor 10 to 10 activated. Factor 10 activated will act on factor 2, which is prothrombin, and that will now cause formation of thrombin, and thrombin will now cause the breakdown of fibrinogen to fibrin, and then also cause a conversion of stable factor 13 to activated factor 13. So factor 13 activated will work on the fibrin and then cause a cross-linking or a mesh. And this is, the whole aim of this is actually to stop the hemorrhage or bleeding. And if we look at the intrinsic pathway, and it's usually known as the contact pathway, where you have prekallikrein and plasma causing a conversion of factor 12 to 12 activated, 12 activated acting on 11 to 11 activated, then 10, 9 to 9 activated. So, but the major thing is by the time you are discussing intrinsic, extrinsic pathway and you have formation of either factor 2 activated, which is the thrombin, and factor 2 activated can actually cause a stimulation of factor 5, which is the labile factor, and factor 8, the anti-hemolytic factor. And if factor 8 is activated to the activated form, it will also lead to, excuse me, it will lead to the activation of 9 to 9 activated. So the whole cascade continues in that way. And all this is important because by the time we come to the therapy and pharmacology, we see that each of these aspects are target points for the drugs that are used for the treatments. So now in terms of classifying anticoagulants, they are basically classified into two: those that are taken parenterally and those that can be given orally. And in each of this group is further broken down to those that act either directly or indirectly. So we're looking at the parenteral formulation now. Those that act indirectly include the unfractionated heparin, low molecular weight heparin, and then fondaparinux. What these ones will do is that they will either inhibit, like unfractionated heparin, inhibit factor 2, 9, 10, 11, which will now have its effects on coagulation. While in terms of the direct acting parenterals, you have those that are direct factor 10A inhibitors, like the danaparoid. Then you have thrombin inhibitors like bivalirudin, agatroban, which are effective substitutes when we have heparin-induced thrombocytopenia. So on the other side, for the oral formulation, we have two major groups. It can be divided into those that act indirectly and then those that act directly. And those that act directly either act directly on thrombin, factor 2A, they're either direct thrombin inhibitors like dabigatran, or the factor 10A inhibitors like the DOACs, the rivaroxaban and edoxaban as examples. Then the oral anticoagulants that work indirectly are mostly VKAs like Warfarin, and then inhibits the factor 10, the vitamin K dependent factors 2, 7, 9, and 10. Now looking at the parenteral formulation, if we look at the unfractionated heparin, the way it works is that it binds and activates antithrombin. And when this occurs, that's where it accelerates the inhibition of thrombin and factor 10. And it also causes a release of tissue factor pathway inhibitor, the TFPI, from endothelium. Now, what are the indications for its use? When there's arterial or venous thromboembolism, it can be used. When you are having an extracorporeal membranous oxygenation, coronary bypass surgery, that can also be used. And then in DIC, in maintenance of indwelling catheters, and even in acute coronary syndrome, that can be used. And then the administration, it can be for prophylaxis, where you use it subcutaneously at 5,000 units, 2 to 3 times daily. Or it can be used in the setting of treating acute coronary syndrome, where an intravenous bolus of 5,000 units or 70 units per kg, followed by an infusion rate of 12 to 15 units per kg. And then it can be used in treatment of venous thromboembolism, where the initial bolus dose is 5,000 units and then 80, and then you step down to 18 units per kg per hour. It has a rapid onset of action, and the half-life is about 1 to 2 hours. And then you can monitor it by using the activated partial thromboplastin time, the APTT. And then also you can use the anti-factor 10A activity to also check or monitor this. What are the side effects with use of unfractionated heparin? Generally bleeding, and then it can cause heparin-induced thrombocytopenia, osteoporosis, and then elevation in liver enzyme, some hepatitis. So the antidote for it, if you have toxicity with this, is use of IV protamine sulfate, where you expect 1 milligram of IV protamine sulfate to neutralize about 100 units of heparin. Next, parenteral one is the low molecular weight heparin, which has the same mechanism of action like the unfractionated heparin, which is that it will activate antithrombin. So its activation of antithrombin is what will accelerate its inhibition of thrombin. So it acts on antithrombin, then antithrombin will now inhibit thrombin. So that way it is acting indirectly. We know it can be used for thromboembolism, whether venous or arterial, in cancer-associated VTE in pregnancy, and even acute coronary syndrome. And for its prophylaxis, we have 40 milligram daily. And then treatments, you can use 1 milligram per kg subcutaneously, 12 hourly, or you can increase this to 1.5 milligram per kg subcutaneously as a daily dose. So in terms of monitoring, factor 10A activity can be used to monitor its effectiveness. And then monitoring is not usually indicated in conditions like pregnancy and renal failure. Also, low molecular weight heparins can cause bleeding, fractures, and hypoaldosteronism. So the antidote is also use of protamine sulfate. Then the next one is fondaparinux. Fondaparinux is a synthetic analog of antithrombin binding pentasaccharide, and it binds to antithrombin and catalyzes factor 10 inhibition by antithrombin. So it's the same mechanism, and then it can be used for VTE prophylaxis, VTE treatment in high-risk orthopedic patients. And then for prophylaxis, the dose is 2.5 milligram daily subcutaneously administered, while it is higher, 5 to 10 milligrams subcutaneously daily for its treatment, and it does not have a specific antidote, and the major side effect is actually bleeding. One thing about fondaparinux is that it is quite indicated in those who are obese, in children, and then individuals with renal failure as well. Then for the oral anticoagulants, so the still on the parenteral, so those that act more or less directly through direct thrombin inhibition, like agobatran. So agobatran binds directly on thrombin, inhibiting its activity, and then can be used in the treatment of heparin-induced toxicity, and then can be administered as continuous infusion. And there's no specific antidote, but fresh frozen plasma can be used for them. While bivalirudin is also a direct thrombin inhibitor and causes back pain, nausea, vomiting, hemorrhage, and hypotension as well. So for the other aspects of the medication, the oral anticoagulants, like the vitamin K antagonist, the prototype Warfarin, it blocks the function of vitamin K epoxide reductase complex, and this leads to depletion of the reduced form of vitamin K that serves as a cofactor for vitamin K-dependent gamma carboxylation of factor 2, 7, 9, and 10. And this leaves the factor with little or no biologic activity, and it also depletes protein C and S. And that is why it is usually not recommended, when there's a setting of heparin-induced toxicity because of its action on depleting C and S, which can lead to much coagulation. So it is indicated in atrial fibrillation, like we know, when there's mechanical heart valves, or in the setting of severe rheumatic valve disease. And then it can be used as prophylaxis and treatment for venous thromboembolism. So the administration, it is usually administered at a dose of 5 to 10 milligrams, and then titrated to the desired target INR. And lower doses are used for patients that have CYP2C9 or vitamin K epoxide reductase 1 polymorphism. And then it can be used for treatment of VTE and can be administered concomitantly with parenteral anticoagulants like low molecular weight heparin And we can do this for a minimum of 3 to 5 days. However, low molecular weight heparin can be discontinued when the target INR has been achieved within 2 straight days. And the reason for this is that initially it is procoagulant, and then warfarin has a slow onset of action as well. Then in terms of its monitoring, we know it has a narrow therapeutic window, and then it has wide patient variability. Then normally we would want the target INR to be between 2 and 3, but when there's mechanical heart valves between 2.5 and 3.5. A major side effect with use of warfarin is the bleeding can cause the skin necrosis, fetal abnormalities. It has many drug and food interaction as well. And then whenever there's toxicity, vitamin K can be the antidote, as well as 4-factor prothrombin complex concentrate. This 4-factor prothrombin concentrate actually contains these factors 2, 7, 9, and 10, which are usually depleted in the setting of action of warfarin. And the other one is the direct oral anticoagulants, which include those that act direct thrombin inhibitors, and then factor 10A. So the initial ones are factor 10A inhibitors like rivaroxaban, apixaban, edoxaban, and they act by inhibiting directly factor 10A, and they are useful in stroke prevention in non-valvular atrial fibrillation, also in prophylaxis and treatment of venous thromboembolism, and then with aspirin for secondary prevention of coronary artery or peripheral artery disease. There are studies that have shown to support this. And then for thromboprophylaxis after elective hip or knee arthroplasty. And then for prevention of thromboembolism after PCI with non-valvular. Yes. So the doses as outlined. And then there's rarely a need to monitor them, but if you have to, then it's the anti-factor 10A. And it can cause bleeding and dyspepsia, and then they have an antidote, which is the adenosine alpha, and then can also give them the 4-factor concentrate, the prothrombin complex concentrate. Then for the direct thrombin inhibitor, the dabigatran, can also be used for the same things as above, and then the administration dose is above, then its antidote is idarucizumab. So when we look at all of these at a glance, this slide is just talking about the oral direct anticoagulants when you look at them at a glance and compare them with warfarin based on one, the administration, the half-life, renal excretion. Warfarin is majorly excreted hepatically, so there's no renal excretion for warfarin, it's 0. And then we can see that dabigatran has the highest renal excretion, 80%, followed by edoxaban, and the least for renal excretion is apixaban. No wonder it can be used in renal patients, even at reduced or adjusted doses. But in terms of half-life, warfarin has a much longer half-life of about 40 hours compared to the other oral anticoagulants. So now looking at the pathways, the sites of where they do act, whether you are looking at it from the intrinsic or the extrinsic pathway, and even the common pathway which the intrinsic and extrinsic share. By the time you have factor 12 to 12 activated, 12 activated activating, 11 to 11 activated, and then 11 activated activating 11, 9 to 9 activated, and in the presence of activated factor 8, and in the terms in presence of calcium as well. So what you have is that this complex is called the factor X activating complex. And it is this complex that will now activate 10 to 10 activated. So 10 activated in the presence of activated 5 and calcium will now cause an activation of prothrombin, which is factor 2 to thrombin 2 activated. So you can see that fondaparinux, which is written here in this arrow here in blue, what it does is that fondaparinux will activate. So its action is indirect. So it's an indirect factor 10 inhibitor. So it will act indirectly on factor 10 on antithrombin 3. So by the time it acts on antithrombin 3, binding to it, it will catalyze factor 10A inhibition by antithrombin 3. Okay, so that's how it works indirectly. Okay, so antithrombin 3 will now inhibit the factor 10. And of course, when factor 10 activated is inhibited, the cascade will not go on to the formation of the cross-link and the thrombus formation. Likewise, if you go through the extrinsic pathway, remember that presence of tissue factor. So if you have a tissue factor inhibitor, like the unfractionated heparin, it helps to release tissue factor inhibitor from the endothelium. It can block even this cascade as high as this pathway. However, at the level of factor 10A, our novel oral anticoagulants, or the DOACs, they act by inhibiting, okay, directly, they can inhibit factor 10A. And then heparin, low molecular weight heparin, they also act like fondaparinux. They would activate antithrombin, which will now act on factor 10A. So they are acting indirectly. And then you have the intravenous agatroban, divalirudin. They are going to act directly on thrombin. So these parts are very, very important to recall as where they act and exert their effect, which helps in anticoagulation. Okay, so in terms of now looking at the monitoring, so we can do the activated partial thromboplastin time. Can be used in terms of monitoring whether we're looking at the intrinsic pathway, which is from factor 12, or we're looking at the extrinsic pathway, which is from factor 7, or even the common pathway, which they share from factor 10 and factor 5 combination to cause prothrombin to be broken to thrombin. So, however, it's important to also know that if we're looking at measuring or monitoring what happens from prothrombin to thrombin, then we can use the thrombin time, which is a TT. The thrombin time measures what happens on this thrombin to the fibrillation, while the prothrombin time helps in actually monitoring the common pathway, because whether it's intrinsic or extrinsic, the common thing is that at the end, they will cause prothrombin to be activated and form thrombin. So this common pathway can be assessed using prothrombin time as measurement. So now one of the common effects we can have when we use heparin is the fact that they can develop heparin-induced toxicity, which is HIT. There are basically two types, HIT1 and 2. Normally, HIT1 occurs in the first 24 hours as a result of the platelet binding to heparin, and this is usually mild, while the type 2 usually occurs in 5% of treated patients with heparin, and this one is known to paradoxically cause thrombosis. And it is caused by an antibody-mediated process that is triggered by antibodies directed against new antigens on platelets for TF4 that are exposed when heparin binds to this protein. So just look at this diagram by the side, you can see here, and then you have heparin coming to bind to this protein, and that is what actually leads to this process of heparin-induced toxicity. And then such binding activates platelets and generate platelets microparticles, which are prothrombotic. So to help us remember, there are 4, some people say 5 T's for the HIT. At first, you have a thrombocytopenia, which is a platelet count less than 100,000, or a decrease in platelet count more than 50% from the baseline. So also in terms of the timing, mostly HIT1 occurs earlier within 24 hours, but HIT2, which is the one with most significance, occurs within 5 to 14 days after starting heparin. That's when you have the fall in terms of the platelet count. And then it is mostly common with use of unfractionated heparin than with low molecular weight heparin. And then mostly the patients are surgical patients and patients with cancer, and it's more common in them than general medical patients, and it's more common in women than it's found in men. Then the other thing is that venous thrombosis are common than arterial thrombosis in HIT. So HIT diagnosis can be done using enzyme-linked assays to detect these antibodies that are against heparin P4 and complexes found on the platelets. And then, but the most specific way to do this is actually checking for serotonin. And in terms of treatment now, first thing you want to do when there's heparin-induced toxicity or thrombocytopenia is you want to stop all heparin. And then you can give alternative anticoagulants like agatroban, bivalirudin, fondaparinux, or even rivaroxaban. And then it is usually not advised to give platelet transfusion, because one would think that the next thing one would think of actually, since there's a depletion in platelets, the thought would have been that to give platelets to be part of the treatment. Okay, but it has been shown that platelet transfusion in heparin-induced thrombocytopenia actually precipitates thrombotic events, and studies have shown this. So you do not give platelet transfusion, and then you do not give warfarin until platelet count return to normal. Remember that warfarin has significant effect on protein C and S, so that would worsen thrombosis or coagulation. So, and then you evaluate for thrombosis, and then particularly deep vein thrombosis. So there are different studies that have been done, and they have shown importance of use of anticoagulations in different conditions. The first one is when there's coronary artery disease in a patient undergoing PCI with comorbid non-valvular atrial fibrillation. So there's non-valvular atrial fibrillation. Studies like the Pioneer AF PCI, the Redual PCI, and the Augustus trials have shown that apixaban, dabigatran, or rivaroxaban in combination with a P2Y12 inhibitor like clopidogrel, prasugrel, or ticagrelor is useful or helpful. And then for valvular AF, the Realign trial showed that warfarin is the mainstay for its use. And then for the stable atherosclerotic cardiovascular disease patient, the COMPASS trial has shown that, and those that have peripheral vascular disease, COMPASS trial showed the use of rivaroxaban and antiplatelets, in this case, aspirin. While the AFIRE study has shown the importance of use of rivaroxaban in patients with stable atherosclerotic cardiovascular disease and atrial fibrillation. While cancer-associated thromboembolism, historically we use low molecular weight heparin, then we have new evidence to support the use of the oral anticoagulants like apixaban. And you can see this in the ADAM VTE or VTE cancer studies. While in terms of chronic kidney disease patients, where we will need those adjustments because of the renal clearance, but for most of them, apixaban can actually be used even when the creatinine clearance is less than 15 minutes per minute, by 1.73 for them, while the others would need more, mostly those adjustments and even avoidance as you have the EGFR declining. However, even when the EGFR is less than 15, apixaban can be used. And then for patients that have hepatic impairment, And it's been shown that the oral anticoagulants can be used in patients that have mild hepatic impairment, those with like type 2A, and then warfarin can be used for those in type 2B and C, even though this has to be guarded because we know that the metabolism for warfarin is mostly hepatic. And then pregnancy, mostly low molecular weight heparin is preferred. Then for terms of procedural management, so in procedural management of the new oral anticoagulants, their renal function levels. So we have a study that compared, dabigatran, rivaroxaban, and apixaban, diethrombin inhibitor, factor 10A on the other side. And then you make adjustments, one based on what is the expected bleeding risk. So is the expected bleeding risk low or high? Okay, so is it low? That's mild or moderate anticoagulant effects is expected or accepted for that patient? Or is the bleeding risk high, or there's neurologic intervention, no minimal anticoagulant effect required? So the first thing is for each of them, you see that when the renal function is normal and when the renal function is impaired. Now for dabigatran, the half-life is 12 to 17 hours. So when you have renal function, normal renal function, and then the expected bleeding risk is low, you are to stop dabigatran use 24 hours before the procedure. However, if the bleeding risk is high, you stop it even earlier, before then, like 48 hours, okay? And then if there's impaired renal function or the patient's age is more than 75, if there's low risk of bleeding, you stop 36 hours before any procedure. And then the risk is high, is even much longer, 72 hours before that. So adjustment in terms of pre-procedural management is important for the patient based on their renal function. While in terms of warfarin for peri-procedural management, so you ask questions like, is interruption of anticoagulation needed? So this has to be answered. It will either be yes or no. So if there's no need for interruption, so you continue anticoagulants, for example, those that already have pacemakers, dental extraction, and all that. But if there's need for interruption of anticoagulant, then the next question to ask is whether there's need for bridging anticoagulants. If there's need for bridging anticoagulants, then you might want to use low molecular weight heparin. And then if there's no need for bridging anticoagulants, then you might want to stop warfarin about 5 days before procedure. So anticoagulants are contraindicated, absolutely, and in some conditions relatively. So when there's an active ongoing bleeding, of course, you don't want to use them because they worsen bleeding. And the setting of coagulopathy, or a patient has just had a very recent major surgery, risk of bleeding is high. For a patient with an acute intracranial hemorrhage, you may not want to start that patient on anticoagulant. However, there are relative risks. For example, a patient has GI bleeding, maybe upper GI bleed that it's currently not significant or ongoing. You can check the risk benefits to see the patient benefit from that. And then those that have had low risk surgeries that maybe be not be ambulant, may want to consider that patients with aortic dissection or aneurysm. And then in terms of those who are at the geriatric age range and those who are pregnant, it is advised that we use anticoagulants cautiously then. Okay, so in terms of duration of the use of anticoagulants, it can be prolonged if the risk of repeat thrombosis is high. For example, those who have provoked thromboembolic phenomena. So you want to give them a prolonged period after an initial 3 to 6 months. And then some patients may benefit from prolonged anticoagulation. And of course, this is based on case-by-case basis, and no one caps fits it all. So we have to evaluate each patient and decide for each one of them. Okay, so and ultimately,
Toby, if you can round up in the next 5 minutes.
Okay, so thank you. Regardless of the anticoagulant duration, the risk of bleeding should always be compared against the risk of recurrent VTEs. Okay, so the anticoagulant duration, I've talked about this already, depending on whether it is provoked or unprovoked. And then we'll have to risk stratify each patient. Then this slide just compares heparin and warfarin. I think we can look through this later. Then the next slide is one of the side effects of use of warfarin, which is the necrosis that it can cause. Then quickly, I'll just point out some studies that have been done. First, starting with atrial fibrillation or atrial flutter. There has been studies like on vitamin K antagonists. And this is a summary of vitamin K antagonist study, a meta-analysis where compared with control or placebo, vitamin K antagonists, primarily warfarin, reduces stroke risk by 64% and mortality by 26%. Currently, the only treatment with established safety in AF patients with rheumatic mitral valve disease and or artificial heart disease is use of VKA. So the use of VKA is limited because of the narrow therapeutic interval necessitating frequent INR monitoring and dose adjustment. And then we should usually have a time in the therapeutic range more than 70% for its effectiveness. And then VKAs are effective, and then they're relatively safe drugs. So this meta-analysis actually buttressed that fact that adjusted dose warfarin and antiplatelets regimens reduced by approximately 60 and 20% respectively in patients with atrial fibrillation. So warfarin is substantially more efficacious than antiplatelet therapy. So absolute increase in major extracranial hemorrhage associated with antithrombotic therapy in participants from the trial included in the meta-analysis were less, and the absolute reduction in stroke, judicious use of antithrombotic therapy importantly reduces risk for most patients who had atrial fibrillation. Okay. Another study is the new oral or the novel oral anticoagulants, and it was a comparison of the efficacy and safety of the novel oral anticoagulant with warfarin in patients with atrial fibrillation. So, and then the summary majorly is that the major summary here is that they noted a heterogeneity for stroke or systemic embolic events in important groups, but there was a greater relative reduction in major bleeding with new oral anticoagulants when the center-based time in therapeutic range was less than 66 than when it was 66 or more. So in this study, what they found out more was that the GI bleeding was less with use of the novel oral anticoagulants compared with use of warfarin. We can look through this after now. Then another study was on deciding on warfarin and the novel oral anticoagulants in patients without mechanical valves or moderate to severe rheumatic heart disease. And to be able to do this, there's the some Cential score that we can use to decide which patient would actually need warfarin or which one would need the new novel oral anticoagulants. Okay, and so it has a total score of 8. The first S is for sex. If it's female, you give a score of 1. Age less than 60, score of 1, and then based on the medical history as well, then the treatment. If the patient is on some medications like amiodarone, you give a score of 1. History of tobacco use, school, and then 2. And then the race, if it's not Caucasian, you give 2. So based on the score, you can now say if the patient has a score of 0 to 2, you can place the patient on the VKA. And then you have to look at the time in therapeutic range. So your aim is to have a time in therapeutic range of more than 65. However, if your time in therapeutic range is less than that, you want to consider use of NOACs. And then if the score is above 2 as well. So this shows that if a patient, you have AF patients with prosthetic mechanical heart valves or moderate to severe mitral stenosis. If the answer is yes, you go straight forward to use your VKAs. But if the answer is no, you then identify the risk of the patient. So based on the risk, if your patient is low risk, based on your Chadva score, 0 for male, 1 for female, if this risk is low, there's no need for antithrombotic treatment. However, if the risk is more than that, you want to now calculate if it's more than 1 for male, you consider oral anticoagulants, and then if it's more than 2 for females, and then you also have to calculate the Hasbled score, which is the score that checks risk of bleeding in patients. So there are many of the guidelines. I'll just rush through now because of time. We can look through this after now. So for stroke prevention in atrial fibrillation patients who are eligible for oral anticoagulants, the NOACs are recommended in preference to VKAs. And this is excluding patients with mitral heart valve or moderate to severe mitral stenosis. This is a class 1 level A recommendation. And then for stroke risk assessment, a risk factor-based approach is recommended using Chadva's clinical score to initially identify patients as high or low risk. Okay, those who are low risk should not be offered antithrombotic therapy. Okay, it's class 1A. And then the oral anticoagulant is recommended for stroke prevention in AF patients with Chadva score more than 2 in men and more than 3 in women. And then they should be considered for stroke prevention in AF with patients with Chadva score of 1 in men and 2 in women. And then the important thing is that treatment should be individualized based on net clinical benefit and consideration of patient values and preferences. This is 2A, level of evidence B. And then for bleeding risk assessment, a formal structured risk-based bleeding risk assessment recommendation to help identify non-modifiable and address modifiable bleeding risk factors in all AF patients, and to identify patients potentially at high risk of bleeding who should be scheduled for early and more frequent clinical review. This is at class 1 level B of evidence. So just maybe highlighting some, they're all important. We can look through this, but let me take some. If the vitamin K antagonist is used, a target INR of 2 to 3 is recommended with individual time in the therapeutic range more than 70%. Okay, and then they said antiplatelet therapy alone, monotherapy or aspirin in combination with clopidogrel is not recommended for prevention of atrial fibrillation. Okay, so for patients that have venous thromboembolism, deep vein thrombosis, or pulmonary embolism, unfractionated heparin is preferred in the acute pulmonary embolism, especially when thrombosis is considered. However, if thrombosis is not considered, then we should look more towards using low molecular weight heparin and fondaparinux. Those two are recommended. And then unfractionated heparin is also recommended for patients with severe renal impairment, the creatinine clearance of less than 30 mL per minute, or those who are severely obese, and then mostly as well in children as well. And then in low-risk pulmonary embolism, NOACs can be used in the acute setting. So long-term anticoagulation in pulmonary embolism is with NOACs or Warfarin, but NOACs is preferred because of the relatively low risk of bleeding. So this meta-analysis of this study on direct oral anticoagulants compared with vitamin K antagonists for acute venous thromboembolism, evidence from phase 3 trials, we can see that for the main thing is that the direct oral anticoagulants, they have similar efficacy as VKAs, the treatment of acute symptomatic VTE, but significantly reduce the risk of major bleeding. And then the efficacy and safety of the DOACs in the treatment of acute VTE are consistent and clinically important subgroups. So I will skip through this because it is still buttressing the facts of use of novel oral anticoagulants. And then we have more guidelines from ESC regarding use of anticoagulation in PE and in acute pulmonary embolism. And the initial one is initiation of anticoagulation is recommended without delay in patients with high or intermediate clinical probability of pulmonary embolism while diagnostic workup is in progress. Okay, so we can start off anticoagulation while we're even still trying to, clinch on the diagnosis. And then if anticoagulation is initiated parenterally, low molecular weight heparin or fondaparinux is recommended over unfractionated heparin for most patients, except of course when we're dealing with renal impairment or obesity, or even in children that may now favor unfractionated heparin. And then when oral anticoagulant is started in a patient with pulmonary embolism who is eligible for a NOAC is recommended in preference to a VKA. Then this other part talks about when a patient is on VKA, overlapping with parenteral anticoagulation is recommended until an INR of 2.5 is reached. So remember the range of 2 to 3, and then in mechanical valves 2.5 to 3.5. Then NOACs are not recommended in patients with severe renal impairment during pregnancy and lactation and in patients with antiphospholipid syndrome. This is class 3 level of evidence, but we recall that apixaban has been shown to be useful in patients with renal impairment. So for those who have acute coronary syndrome, in general, a crossover between anticoagulants should be avoided in patients with acute coronary syndrome, especially between unfractionated and low molecular weight heparin, with the exception of unfractionated to fondaparinux when a patient is presenting with non-ST elevation acute coronary syndrome. Okay, and then anticoagulants should generally be discontinued immediately after PCR, except in specific clinical settings, such as the confirmed presence of left ventricular aneurysm, or you have a thrombus formation or AF requiring anticoagulation. Otherwise, after a PCR, it should be discontinued. Okay, and I'll just run through now. This study is on the bivalirudin plus infusion trial and outcome, which showed reduction in primary outcome and even the secondary outcome. And then for the ORC6 trial, which is on the safety and efficacy of fondaparinux versus control therapy in patients with ST elevation MI trial. And then it shows that fondaparinux is not recommended in patients with STEMI undergoing PCI. So this is a summary of the ORC6 study or the program. It had a design where patients with STEMI were randomized less than 12 hours onset. We had over 12,000, and then they were stratified into 1 and 2. A group used fondaparinux and placebo. The other group used fondaparinux, unfractionated heparin, and placebo. And then the primary outcome, the composite of death or reinfarction at 30 days, mean safety and severe bleeding, and it was quite significant to see the drop that occurred with use of this. Then this is still from the study, use of fondaparinux and then enoxaparin in terms of major bleeding through the line, and then mortality, the 30 mortality at 6 months. You can see that they were, it was at 30 days, it was 2.9 for use fondaparinux at 3.5. For enoxaparin for mortality at 6 months, 5.8 and 6.5 for enoxaparin. Then I am rounding up now. So in general recommendation, anticoagulant therapy. Parenteral anticoagulation is recommended for all patients with acute coronary syndrome at time of diagnosis. Okay, and then routine use of unfractionated heparin bolus is recommended in patients undergoing PCI. Okay, for NSTEMI, for patients with NSTEMI, in whom early invasive angiography is not anticipated, fondaparinux is also indicated or recommended for them. Then combining antiplatelets and oral anticoagulants. After the default strategy for patients with atrial fibrillation and Chadva score is more than 1 men and 2 for women, after up to a week of triple anti-thrombotic therapy following an acute coronary syndrome event, dual anti-thrombotic therapy with a NOAC at the recommended dose for stroke prevention and a single oral antiplatelet therapy, preferably clopidogrel, for up to 12 months is recommended. And then during PCI, unfractionated heparin bolus is recommended in any of the following: if the patient is on a NOAC, if the INR is less than 2.5 for a patient who is on a VK, okay? So we can look through all of this later. We just round up for the peripheral arterial disease. The COMPASS trial showed that there was better outcome for those who used anticoagulants like rivaroxaban and aspirin. So that's what the study showed. So those who were on aspirin alone, they had higher deaths, strokes, MI, compared to those that had rivaroxaban and aspirin. So it's better to use both in them. So concluding now that thrombosis involves a complex interplay among the vessel wall, platelets, the coagulation, and fibrinolytic systems. And then despite advances in newer antithrombotic therapy, thromboembolic disorders remain a major cause of morbidity and mortality. Therefore, the search for better and safer targets continue. These are my references. Thank you for listening.
Yeah, well, thank you very much, Dr. Itubi, for a very extensive presentation. There's a lot of stuff. I'm sure people have a lot of questions or comments. So the floor is open. Colleagues to ask questions or make contributions towards the presentation.
Okay, thank you so much, Dr. Alex. This is a norm for you. You always make beautiful and extensive presentations. Okay, so I just have a question. The use of anticoagulants in a pregnant woman with antiphospholipid syndrome. Like, how would you manage a patient who has antiphospholipid syndrome and now becomes pregnant? How will you manage with the use of anticoagulants?
Hello, sorry, I missed for a bit.
Okay, I'm asking a question. Okay, you know there are some health conditions where a patient will need anticoagulants for life, like the antiphospholipid syndrome.
Yes.
Okay,
yes.
so I want to find out, once a patient who has that becomes pregnant, how do we manage, like with the use of anticoagulants, knowing that some are not good in pregnancy and some certain times they don't use them? So, like, how do we manage? Because most times I mix it up. If you know.
Okay. Thank you very much. For antiphospholipid syndrome, the standard treatment we know is use of lifelong anticoagulants, right? So, and most times we would use things like the vitamin K antagonist, one, because availability, two, costs, and all that. But however, in this case now, a patient that becomes pregnant, it becomes dicey, to using them. So the main thing about them is that, they have refractory risk for thrombosis. So they definitely have to be on lifelong anticoagulants. So the low molecular weight heparins have been found to be safe in pregnancy relatively. So if a patient has antiphospholipid syndrome, and is on lifelong anticoagulation with a vitamin K antagonist. I think what to do is now switch the person over to what has been shown to be safer, like low molecular weight heparin, and until after delivery of the baby. I don't know if I answered your question or if somebody has more addition to this, but I read somewhere that this is what you do for them.
I think that there's a point, like after there's a point they now introduce, you can still introduce the vitamin K antagonist. Like I
Yes,
think
yes.
after
So
organogenesis,
exactly.
because
So
because okay,
okay, go
no
ahead, go
problem. Dr.
ahead.
Conte, you can have the floor. No, please, you. Thank you. Let me hear from you, please. I want to hear from you.
Yeah,
Thank you.
I just want to contribute that the recent, I think it's the hematology guideline for anticoagulation. So, the vitamin K antagonists, they affect, as you mentioned, organogenesis. So in fact, the important thing is that for patients who have antiphospholipid syndrome and they want to get pregnant, you want to actually stop their warfarin before they get pregnant. So it has to be planned. Because what happens sometimes, a lot of the patients, they are on the medication, they get pregnant at the time they come and tell you. So a lot of the time, if you're stopping it after they are pregnant, so most of the time, the damage would have been done. Okay. So you want to make sure that you cancel them. It is a planned pregnancy. And when they're ready to get pregnant, you switch them to heparin. Okay. But from the late second trimester, you can actually go back to warfarin once organogenesis has complete. And then it has been shown to be safe. And then during around the delivery period, okay, because of the risk of bleeding around the delivery period, you can also switch to low molecular weight heparin around the delivery period. And then after delivery, everything is fine. The patient can go back to oral vitamin K. Thank you.
Thank you.
Beautifully said. Then also, vitamin K antagonist has been known to cause limb agenesis. Like it can make a fetus, it can actually stop the formation of limbs in a fetus. So that's one of the side effects of vitamin K antagonist in utero if given in that early second trimester. So that's one of the things we try to avoid, and other defects, heart defects, and other things that can occur. Thank you so much, Dr. Conte. That's actually how the patient should be managed. Thank you. Thank you, Dr. Alex, once more
Yes.
for a beautiful presentation.
Dr. Toby, a lot of thanks for you on the page. People are thanking you for the good presentation. And then Pitamba is asking a question. Is it in terms of assessing bleeding risk, is the Hasbled score applicable in all patients, or are there other ways of assessing bleeding risk?
As in has bled in all patients?
Yeah.
There are other criteria for, there are other scoring systems. So has bled is not the only one. I think there are some, like one is called the hemorrhages, atrial score, and all that. I think has bled is favored because of the relatively ease with which it can be used. Okay, but there are other scoring systems that can be used to score. There's one atrial score, there's one hemorrhages score, and I think there are others, can't remember all now. But the key thing is, once you are starting a patient on anticoagulants, one, you have done your Chadva score, especially in AF, and patient merits anticoagulants. The next thing you want to look out for is what is the risk of bleeding in this patient. But if you look at the Hasbled score, it has many clinical, correlation of parameters, like for example, whether a patient is hypertensive, whether there's a stroke, is the patient bleeding, look at the INR. So it's somehow easy to adapt or use, but there are others as well. Thank you. Hello? Sorry, was I heard?
Yes, loud and clear.
Okay.
I think I don't see more question in the chat box. Then there is this thing about dose, adjusting dose when switching from one type of anticoagulant to the other, especially among the NOACs. When you are switching from one to the other, how you switch and how you adjust the dose. I think we've seen sort of questions like that in the MCQs. Did you come across anything like that?
Yes, I saw something like that in terms of the, but it's an extensive table I can send. I didn't add here because of the time.
Okay,
But
fine. You can send to the group. Because I
yes,
remember we came across some MCQ that I was looking at those. Yeah, okay, that's good.
There's something like that that helps you switch, know which one to move to. For example, when you access the type of bleeding, you have to look at, is it a major bleed or is it non-life threatening? For example, if a patient is on, let's say, direct thrombin inhibitor, maybe dabigatran, and then you are looking at it as at the bleed. You look at, is the bleeding life-threatening or non-life-threatening? So you can move between either the thrombin inhibitor or the factor 10A. I saw something related to that.
Good evening. Please, I have some questions and some comments. I don't know if I'm permitted.
Okay, please go ahead.
Thank you. Thank you, Dr. Itubi, for the beautiful presentation. Okay, please, I don't know if you can just kindly just shed more light on one of the complications of warfarin that you mentioned. That's warfarin-induced skin necrosis. Then also, actually also need a clarification. I think when you were talking about the guideline, ESC guideline for the management of acute pulmonary embolism, you talked about the preference of low molecular weight heparin and then fondaparinux to the unfractionated. But at the same, but I think earlier there was an earlier slide where you talked about preference of unfractionated heparin to low molecular weight heparin when there is thrombosis. So there was a bit of confusion there. So I really appreciate if you can shed more light. Then lastly, my third question is, okay, in a patient that is on oral anticoagulant that requires probably a non-cardiac major surgery, what's actually the approach in such patient? Probably patient that will require probably a lifelong anticoagulation, or probably required up to a year or more. How do one approach such? Thank you.
Okay, thank you for those questions. Thank you very much. Talking about yes, one of the complications for use of warfarin is the skin necrosis, which can occur, and it's usually a skin or subcutaneous tissue necrosis, and it usually occurs as a result of when you have a deficiency in protein C. And usually, you know that when you start your, one of the drawbacks or the complication with the use of warfarin is that it can cause a depletion of protein C and then even protein S. Okay. So when you have that kind of rapid loss or destruction or deterioration or deficiency following use of anticoagulants, it can now lead to tissue. Okay, this is what it looks like, tissue necrosis in your patients. Then in terms of you talked about a patient that would require maybe a major surgery, patient that would require anticoagulants and has a major surgery to undergo and may require anticoagulants after 1 year. So the main thing to look out for in that patient is, one, you want to find out what is the risk of bleeding in this patient. Is it a major or minor risk of bleeding? So if you look at the risk of bleeding in your patient, determining whether it's major or minor, That will now, determine how we use, and then based on the anticoagulant as well. Okay, some are discontinued much earlier before, others and later. And then apart from the risk of bleeding, the other things you look out for is the renal function in your patient. Okay, so if the renal function is normal or if it is reduced, that would also impact on when you stop your anticoagulants, because you know that following major surgery, risk of bleeding increases. So you have to stop the anticoagulants prior to, and then recommence shortly after the surgery. Okay, it has been done already. Then I'm not sure I got your other question about fondaparinux and unfractionated heparin.
Okay, actually, there was one of your, I think about 2 slides, when you were talking about the management of acute pulmonary embolism.
Okay.
Then before going to the ESC guideline, you talked about the preference of unfractionated heparin. Okay, I think here.
Yes.
Yes, you, was it here? I know, I think, it was before here. You talked about, so was it a bit confusing? I saw preference of unfractionated heparin at a point, then preference of low molecular weight heparin and fondaparinux over unfractionated heparin. So I just wanted to know at what point, or is there a mix-up? I just wanted a clarification on that. Thank you.
But the thing about it is, but by the time you want to use the fondaparinux, there are guidelines or conditions that favor its use. So going back to, maybe I'll look for the other slide, but the general thing, the recommendation by ESC is that parenteral anticoagulants is recommended for all patients with acute coronary syndrome at the time of diagnosis. Okay, and then use of unfractionated heparin bolus is recommended in patients undergoing PCI. So maybe it was when we talked, I don't know whether it was somewhere here. Sorry.
Hello, Dr. Itubi. I
Yes.
think you mentioned that for those undergoing PCI, then
Yes.
fondaparinux is contraindicated because it is treated with increased mortality. So you can either use unfractionated or low molecular weight if they are going for PCI. Okay.
Yes, please.
Yes, and then for those with acute pulmonary embolism, when you are using parenteral anticoagulant, so it is now low molecular weight and fondaparinux that are preferred over unfractionated heparin. Okay, thank you.
Hello? Hello?
Yeah, you can go ahead.
Okay. So I think the major thing for the two or use of either is like Conte has mentioned. If you are talking about fondaparinux, is usually used when you have when you have acute pulmonary embolism. What has been now recommended is use of fondaparinux or the low molecular weight heparins. Okay, so that is clear in its use. And then it's contraindicated for PCI unfractionated heparin because of the risk associated with thrombosis. That was what I mentioned earlier. I don't know if it's clear now, Dr. Olaleko.
Thank you. It's clear now. Thank you.
Okay, I don't see any more hands up. Our Chief Okopi and Chief Orimolade, if you have any comments, contributions to make.
Thank you so much, Dr. Conte, for that beautiful coordination. Thank you, Dr. Alex. You always impress.
Thank you, sir.
Alex, I'm very, very proud of how much time you give to this presentation. I think this is like a gold standard anticoagulant presentation. Thank you. Just before we make some comment, let me call
Thank you, Chief.
one of our founding members, Dr. Chuka. Thank you for coming. Please, do you have any comment to make?
Thank you, my Oga. No comments for now. It was quite elaborate, extensive, and addressed almost all the issues I would have had questions asking about. So there's really not much I have to say again. Everything has been addressed and quite elaborate too. I think I would advise all those who for the exams to catch these slides and take a look at them. They are quite loaded with a lot of stuff and current information too. Thank you very much for the presentation, sir.
Thank you. Thank you. Thank you. We're always encouraged to come around. Just before we call on Prof, Dr. Okay, Dr. Ayodeji, you wanted to say something? Ayodeji.
No.
All right, okay. So let's call on Dr. Allison before we call on Prof. Ayodeji, Dr. Allison, please.
Thank you, Dr. Okope. Good evening, Dr. Ima. It's nice to have you around. Thank you. Thank you so much, Dr. Alex Utubi, for this very great detailed presentation. I actually also enjoyed it. There was a question that Dr. Conte was trying to ask. There is an article. Remember, we came across some questions on those ones of switching, the ones that we don't really need sulfurclexane prior to giving, and the ones that we need sulfurclexane prior to giving out of the NOACs. So you should please take note of them. So I think it's only dabigatran that we really need to anticoagulate with, to start with sulfurclexane alongside with Warfarin. But for others, we really don't need clexane before administration. And the switching that Dr. Conte was talking about, there's one article on it. As soon as he asked the question, I tried checking my phone. So I think I will have to check my laptop. We have to also check that, because there were some questions we answered. I'm not sure which, if it was in Brownworth or some other questions. So there's one article that contains some of the information that we have to know concerning that. Then we should always not forget, although he addressed part of the concerns, the ones that we actually need to renal dose and the dose at which you renal dose them for use. So we should please try to check that. Dr. Alex Esubi, I'm not sure if you remember this question. Was it in exam that they asked them about, they talked about which the NOACs, that was the way they asked the question, that which of all the NOACs is it we have the least effects of bleeding, and probably maybe why, or at what dose or something. Can you remember?
Yeah, there was something like that, but
was it in our exam? Yes. So I remember we should try to look at apixaban as the least. Everyone we give bleeding, but apixaban we have the least side effects of bleeding compared to other ones. So we should still please check it up. So the ones that gives the highest, let me say, risk benefits, I mean risk, the highest risk of bleeding, we should know. The one with the least bleeding risk, we should also note. I think that question came in our exams, please. So let's take note of that. Then another question too that came to mind as it was presenting is the ones, there's a study on this triple we have dual antiplatelet therapy and the triple antiplatelet this thing following stenting. So which of them do we actually use and what dose? I think it's apixaban and Dr. Etubi. I'm not. Do you remember that?
I didn't remember that. I don't.
There's one when we talk of triple, we use them 2 antiplatelet plus 1 anticoagulant. So I'll look for the study and give us, I think it's apixaban and the dose where we use the dose that we use and the study that supports it. We had a question like that in exam. It's actually a recent study. So I will look for that study and probably put it on the group. I think those are the few comments, but please, just like Dr. Yema said, we have to go through these slides. Anticoagulants will come out. I don't think we can escape it. And it's also could be a possible OSCE question, really. We had anti-angina. They might not repeat anti-angina. So antiplatelets, anticoagulants, hypertension. So just as we are saying it, we might not have time to go back to these drugs again. So the moment we treat them, please, let's just digest and forget about it, you get. So it's always better that way. Thank you so much, Dr. Etubi, for this wonderful presentation.
Thank you very much, Chidma. Thank you for those very helpful comments.
Thank you so much, Dr. Allison, Dr. Alex. This is a very brilliant presentation. I don't know if you searched through Oxford and book and you saw mechanical heart valves and anticoagulation in pregnancy. Dr. Alex, I don't know if you saw something like that.
Mechanical heart valves?
Yes, and anticoagulation in pregnancy.
I didn't look through that, sir.
Okay, there's a couple of interesting stuff there. Just of anticoagulation. I can't remember. I think when I was going through for my own exam, I think page 688 or 87. If we have Oxford, please check it. And then they also give a detailed anticoagulant choice in pregnancy. Some of the things that Conte said, and also Florence. You can see them in that page, those pages. I had to remember the pages because they are quite interesting stuff.
Wow.
So page 688 or 687, mechanical heart valves, anticoagulation in pregnancy, during delivery, prior to delivery, they independent on the kind of heart valves used and what anticoagulation, and then the choice of low molecular weight, reasons which one crosses the placenta, and all the other side effects of Warfarin. I think maybe if you can just have time to check through it. If I have the book, I'll snap the pages.
Okay, sir. Okay, sir.
A very beautiful presentation. Thank you for always representing your clan. Thank you so much. So Dr. Conte, thank you. Over to you.
Thank you very much, sir. Thank you, senior colleagues. Thank you.
Okay, thank you very much, our chiefs. And big thank you to you, Dr. Etubi, for a very presentation. And please make the slides available to us as early as possible. So we'll continue with the second segment for this evening.